think about it, almost everyone knows someone who's had their appendix out, right?
Definitely. It's
Yeah.
incredibly common.
Yeah, it's the super common surgery, but like, how much do we actually know about the appendix itself before it causes all that trouble?
Probably not much for most people, I guess. It's
Oh.
just sort of there,
Exactly. Well, that's what we're diving into today. We're going deep into the medical literature.
right? Using textbook chapters, diagrams, the whole 9 yards.
Our mission basically is to get beyond just, it hurts, take it out, and find out some surprising stuff about its anatomy, what goes wrong, even the history of the surgery.
And for you listening, this should be a really good way to get up to speed. Lots of aha moments, hopefully, but not too overwhelming.
Definitely not. Okay, so let's kick things off. Where exactly is this appendix hiding?
Okay, so the appendix,
Mhm.
it sits right at the very beginning of the large intestine. There's a part called the cecum.
The cecum, right.
And if you picture the cecum, it has these 3 bands of muscle running along the outside, the tene coli. The appendix doesn't just attach anywhere. It sprouts right from the spot where those 3 bands all come together.
Ah, okay, a specific junction point.
Exactly. And that point is usually only about 2 centimeters below where the small intestine, the ileum, joins the large intestine. That little connection is the ileocecal orifice.
So it's really tucked in right there at the start, almost like a little pouch off the side.
That's a good way to think of it. Little cul-de-sac.
Okay. Now, what about size? Is it like one size fits all, or does it vary?
Oh, there's definitely some wiggle room. Lengthwise, typically around 5 to 10 centimeters,
Yeah.
so a few inches.
Okay.
But the really interesting part, I think, is the inside, the hollow bit, the lumen.
Yeah.
It's tiny, like the thickness of a matchstick.
Yeah, really? That narrow?
Yeah, we're talking a diameter of only 1 to 3 millimeters for the lumen. The whole appendix itself is a bit wider, maybe 3 to 8 millimeters across.
A matchstick. That really puts it in perspective. Okay, I saw this term in our sources. The mesoappendix. What's that about?
Right, the mesoappendix. Think of it like a little sling or support structure, just for the appendix.
Okay.
It's basically a fold of the mesentery, the tissue that holds the intestines and carrying blood vessels.
Well, how the mesentery got it.
So the mesoappendix is part of that. And what's really crucial is that it contains the main artery for the appendix. That's the appendicular artery.
The main blood supply.
Exactly. It branches off another one called the ileocolic artery. And sometimes there's even an extra little artery called the artery of Sachaglum.
An accessory one.
Yeah. And this blood supply is absolutely vital because if one of these arteries gets blocked, say by a blood clot,
That's bad news.
very bad news. That's what leads to gangrenous appendicitis. The tissue dies because it loses its blood flow.
Yikes. Okay, so that mesoappendix and its artery are super important. Now, another term that jumped out was the abdominal tonsil? That sounds kind of weird.
It does, doesn't it? But it's actually quite descriptive. See, inside the appendix wall, in a layer called the submucosa, there are loads of these clusters of lymphatic tissue. Immune cells, basically.
Oh, like lymph nodes.
Sort of, yeah. These lymphatic aggregations or follicles. Because there's such a high concentration of them, it's sometimes called the abdominal tonsil.
Suggesting it has an immune function, maybe?
Exactly. It points towards a potential role in the body's immune system. Maybe sampling gut contents or something.
Abdominal tonsil. Makes you wonder if it's not quite as useless as people think. Okay, zooming in even more microscopically, what's the appendix lining like?
The very inner lining, the mucosa, it's made of cells called columnar cells.
Yeah.
Similar to other parts of the gut.
Yeah.
And it has these little pits or glands called crypts. Oh, and a neat little detail. Where the appendix opens into the cecum, there's usually a small flap of tissue.
A flap.
Yeah, called the valve of Gerlach. It sort of guards the entrance.
A valve for the appendix. Who knew? Anatomy's wild. Now, bodies aren't always textbook perfect, right? Does the appendix always sit in that same spot?
Not at all. There's actually quite a bit of variation in its position.
Really?
Yeah. The most common spot, maybe 75% of the time, is tucked behind the cecum. That's called retrocecal.
Behind it, okay.
But the next most common, maybe around 20-21%, is down in the pelvis. Pelvic position.
Pelvic, wow.
And then there are rarer spots. Sometimes it's in front of the ileum prelial or behind the ileum postelial. That's actually the rarest.
Postelial. Sounds tricky to find.
It can be. Other spots include alongside the cecum, coccygeal, just below it, subsacral, maybe 2%, or even way up under the liver subhepatic.
Under the liver.
Yep. Our sources even had a picture, figure 24.4, showing a subhepatic one during laparoscopy.
Ugh.
So yeah, it can really wander.
That definitely explains why diagnosing appendicitis isn't always straightforward. The pain might not be where you expect.
Exactly. And the sources mentioned something called a subserosal location.
Right. Does it make surgery harder?
It can, yeah. So usually the appendix hangs relatively freely, attached by its mesoappendix, but sometimes it can be partially or even fully embedded within the wall of the cecum itself.
Inside the wall.
Kind of, yeah, just under the outer layer of the serosa.
Yeah.
So being subserosal means it's harder for the surgeon to, dissect it out cleanly during surgery.
Makes sense, like it's fused to the wall almost.
A bit like that. And of course you have cetus inversus.
Oh, yeah, where everything's flipped.
Right. So in those rare cases, the appendix would be over on the left side.
Left-sided appendicitis. Okay, now this next one sounds really out there. Appendix duplication. Can you actually have two appendices?
Believe it or not, yes. It's
Wow.
very rare, but it happens. There's even a classification system for it, the Walbridge classification. Figure 24.3 shows the types.
No way. What are the types?
Well, a type A is like a partial split. One appendix starts, then divides, but still comes off a single cecum.
Okay.
Type B is two completely separate appendices, but both attached to the same single cecum.
Two distinct ones.
Yep. And type C, the rarest, is where you actually have two separate cecums, and each one has its own appendix.
Double everything. That's
Yeah.
wild. Okay, so we've got a much better picture now of the appendix itself, where it is, its size, variations, even having two. Let's shift gears to the main event for many people. Acute appendicitis. What's actually happening when it gets inflamed?
Right. So acute appendicitis, in simple terms, is just inflammation of that little appendix, and it's super common.
Yeah.
Our sources even have this quote from Thomas Hodgkin way back in 1836.
Oh, yeah. What did he say?
He was describing what happens when it perforates, bursts, and how the inflammation could just spread everywhere and, well, often be fatal back then.
Wow. Really puts into perspective how far medicine has come.
Definitely. His description really highlights the danger before we knew how to treat it effectively.
So who tends to get appendicitis? Is it more common in certain groups?
Well, the data suggests it's slightly more common in young males and also seems to be seen more often in white populations. Interestingly, there's even a bit of a seasonal thing going on.
Seasonal, like a cold.
Sort of. Higher numbers tend to be reported around May and August, sometimes called epidemic appendicitis, though we don't fully know why.
Weird. Any other factors?
Lifestyle might play a role. The sources suggest a low-fiber diet could increase risk.
Ah, the fiber connection.
Yeah, and conversely, high fiber might be protective. Genetics could be involved too. About 30% of childhood cases have a close relative who's also had it.
Interesting. So a mix of things. Now, what actually triggers the inflammation? What kicks it off?
It could be a few things. Sometimes, maybe a viral infection causes swelling in the appendix lining, the mucosa. That swelling can then make it easier for bacteria to invade secondarily.
Okay, so infection first.
Potentially.
Yeah.
But the most common direct cause is actually a blockage, an obstruction of that narrow inner channel, the lumen.
A blockage leading to obstructive appendicitis.
Exactly. That's the classic scenario we often think about.
And what usually causes the blockage? What gets stuck in there?
The number one culprit is something called a phacolith.
Phacolith.
Yeah, basically a small, hardened lump of stool. Think of it like a tiny stone made of feces. Our sources have pictures. Figures 24.6 and 24.8 show them.
Okay, a little poop stone. Got it. What else can block it?
Well, it could be a narrowing of the appendix itself, like a stricture. Or maybe a foreign object someone swallowed.
Like a seed or something.
Possibly, yeah. Or even parasites like roundworms or threadworms can clog it up.
Ew.
Uh-huh. Also, adhesion scar tissue from previous surgery or inflammation could kink the appendix. Or even pressure from something nearby, like a carcinoma in the cecum or inflammation from Crohn's disease.
So external pressure too.
Yeah. Even things like a blockage further down the colon or, interestingly, abusing strong laxatives have been implicated. Lots of potential roadblocks.
Definitely a variety of things. Once it's blocked and inflamed, what kind of bacteria usually cause the infection?
It's generally the usual suspects from our gut. E. coli is the big one found in maybe 85% of cases.
Okay, E. coli.
Enterococci are also pretty common, maybe 30%.
Mm-hmm.
And then you get a mix of others, different types of streptococci, anaerobic bacteria like Clostridium welki, Bacteroid species.
So basically our normal gut bugs getting trapped and causing trouble.
Pretty much, yeah. They get trapped in that inflamed, blocked space and just multiply.
Right. Now the sources mentioned different ways appendicitis can develop, differentiating between obstructive and non-obstructive. Let's start with non-obstructive. How does that work?
Okay, so non-obstructive appendicitis means you get inflammation, often with that secondary bacterial infection, but without a physical blockage of the lumen.
So no phacolith or kink involved initially.
Right. And the interesting thing here is the outcome can vary. It might actually settle down on its own.
Oh, really?
Yeah, it could resolve. Or it could lead to scarring, fibrosis inside the appendix. Or it could set someone up for recurrent attacks later on.
So it comes back.
Potentially. Or the inflammation and swelling itself could eventually cause a blockage, leading to obstructive appendicitis down the line. So it's a bit more unpredictable.
Gotcha. A less definite pathway. Now, what about the more perhaps typical obstructive appendicitis? Walk us through that chain reaction.
Right. The obstructive kind usually follows a more defined and often more serious path. It starts with that blockage, the phacolith, the kink, whatever it is.
Okay.
That stops the normal mucus and fluid produced inside the appendix from getting out. So it builds up.
Pressure increases inside.
Exactly. Intraluminal pressure goes up.
Yeah.
This pressure then starts squashing the tiny blood vessels and lymphatic channels in the appendix wall.
Cutting off circulation.
Pretty much.
Yeah.
It blocks the outflow of venous drainage and lymphatic drainage first. This leads to swelling, edema in the wall. The lining, the mucosa, gets damaged, maybe ulcerated, and importantly, ischemic, it's not getting enough oxygen.
Okay, tissue damage starts.
And that damaged lining lets the trapped bacteria break through the wall. We call that bacterial translocation.
The bacteria escape.
They start moving through the layers of the appendix wall, submucosa, muscle layer. The infection spreads. Eventually, this whole process can block the main artery supplying the appendix, the appendicular artery.
Ah, the one in the mesoappendix.
That very one. Thrombosis of that artery means no blood flow at all, and that leads to gangrene and whey, and the tissue dies completely.
And then perforation.
Yep. The dead, weakened wall ruptures, it perforates, usually at the tip or sometimes near the base. Figures 24.7 and 24.9 show this.
And that spills everything into the abdomen.
Exactly. Infected material, bacteria, it spills into the peritoneal cavity, causing peritonitis, widespread inflammation of the abdominal lining, a surgical emergency.
That sounds incredibly fast and dangerous. What happens right after it perforates? Does the infection just spread everywhere immediately?
Not always instantly. The body tries to fight back, to contain it. Often this sheet of fatty tissue called the greater omentum.
The omentum, right?
Yeah, it acts like an apron. It, along with loops of the small intestine nearby, can migrate towards the inflamed appendix and try to wall off the perforation.
Like building a little barrier.
Exactly. If they succeed in containing the pus, you get an appendicular abscess, a localized collection of infected fluid. Figures 24.25 and 24.26 illustrate that.
Okay, an abscess.
Sometimes, especially if the process is a bit slower, this walling off happens, but maybe without forming a large amount of liquid pus initially. That's called an appendicular mass, or phlegmon, more of a solid inflamed lump.
Gotcha. Mass versus abscess. Now, I also saw mucocele mentioned. Is that related to the infection process?
A mucocele is a bit different. It happens when the very opening of the appendix into the cecum gets blocked, usually slowly, maybe by scar tissue or a benign growth.
So blockage at the entrance.
Right. This stops the mucus that the appendix lining normally produces from getting out.
Yeah.
So mucus builds up, distends the appendix, makes it swell up like a little mucus-filled balloon. That's a mucocele.
Is it infected?
Not necessarily at first. It's often sterile mucus. But it can get infected later, turning into what's called an empyema of the appendix, basically, plus inside the mucocele.
Okay, so mucocele is more about mucus buildup. Now, the sources also broke down acute appendicitis into a few types beyond just obstructive. What were those?
Right. We also have recurrent appendicitis. That's when someone has repeated attacks that seem like appendicitis.
Comes and goes.
Yeah. Often thought to be from previous mild, non-obstructive episodes that cause some scarring or adhesions, making it prone to flaring up again.
Okay.
Then there's subacute appendicitis, which is just a milder, maybe more drawn-out version of the acute inflammation.
It's less intense.
Exactly. And then stump appendicitis. That's a newer thing, really relevant since laparoscopic surgery became common.
Stump?
Yeah. If during an appendicectomy, especially a laparoscopic one, a small piece of the appendix base is accidentally left behind, that remaining stump can get inflamed later on.
Wow, you think it's gone, but a little bit remains and causes trouble.
It's rare, but it happens.
Okay. Let's move to clinical features. What are the classic signs and symptoms someone or their doctor should look out for?
Pain is almost always the first thing. And typically, it starts as this vague, sort of achy pain around the belly button, the umbilicus.
Central pain first.
Yeah, that's the visceral pain from the appendix itself being stretched or inflamed. Then usually over several hours. As the inflammation spreads and irritates the lining of the abdomen, the parietal peritoneum,
Uh-huh.
the pain shifts. It moves down and to the right, settling in the right iliac fossa, that lower right part of the abdomen.
Mm-hmm.
Can it become sharper, more localized there?
To classic RIF pain.
Exactly. If the pain suddenly becomes really severe and spreads all over the abdomen, that's a big red flag for perforation.
Okay. What about other symptoms?
Nausea and vomiting are very common. Often happens after the pain starts due to reflex irritation. And then there's the classic, though not universal, Murphy's triad.
Murphy's triad. What's that sequence?
Pain first, then vomiting, and finally a fever develops last. Pain, vomit, temperature.
Good mnemonic. Pain, vomit, temp. Any other signs? Bowel changes?
Usually people are constipated. But sometimes, especially if the appendix is irritating the bowel nearby, like in a posteal or pelvic position, they might actually have diarrhea.
So diarrhea is possible too.
Yep. A low-grade fever is common. Maybe a slightly fast heart rate tachycardia.
Oh.
And sometimes bad breath, phitororis.
Bad breath. Really?
Yeah, it's a non-specific sign of illness or infection sometimes. Also, if the appendix is near the bladder, it can irritate it, causing urinary frequency.
Makes sense. Now, what about the physical exam? What does the doctor look for?
Tenderness is key. Pressing on a specific spot in the right lower abdomen, McBurney's point usually hurts.
McBurney's point tenderness.
Right. Even more specific is rebound tenderness or Blumberg sign. That's when the pain is worse when the doctor quickly lets go after pressing down.
Pain on release. Ouch.
Exactly. It suggests peritoneal irritation. Another sign is Rovsing's sign. Pressing on the left lower abdomen causes pain over on the right side.
Referred pain again. Interesting.
Yeah, suggests the inflammation is irritating the peritoneum, more generally on the right.
Our sources mentioned some specific tests related to where the appendix might be hiding, like behind the cecum or in the pelvis.
Right, those special tests. Cope-Soas test is for a retrosacral appendix. You have the patient lie on their left side and extend their right hip back. If that stretches the psoas muscle, which is right behind the cecum, and causes pain, it points to a retrosacral position.
Okay, stretching the hip muscle.
Then there's the obturator test for a pelvic appendix. You flex the patient's right hip and knee, then rotate the hip inwards. If that irritates the obturator internus muscle in the pelvis, causing pain, it suggests a pelvic appendix.
Rotating the hip inwards?
Yep. There's also Baldwin's test, another one for retrosacral patient lies flat, lifts both legs straight up, and the doctor pushes on the flank. Pain suggests retrosacral.
Okay. Any others?
A rectal exam might show tenderness high up on the right side if it's pelvic. And sometimes there's hyperesthesia, increased skin sensitivity in Sharon's triangle.
Sharon's triangle, where's that?
It's an area on the lower right abdomen, bounded by the hip bone, the belly button, and the pubic bone. Figure 24.12 shows it. Just touching the skin there might feel unusually sensitive.
Wow.
And as things progress, the doctor might even feel a lump, an appendicular mass or abscess. Plus, things like coughing making the pain worse, Dumphy sign, or even shaking the bed gently, Baphat test, or having the patient drop onto their heels, heel drop test, can increase the pain.
Lots of subtle signs to look for. Now, does appendicitis look the same in everyone? The sources mention differences in babies, kids, the elderly, and during pregnancy.
Yeah, presentation definitely varies. In infants, it's rare, but really dangerous when it happens. Very high perforation rate, like 80%, and sadly, high mortality too, maybe 50%.
So serious in babies.
Very. In children, their omentum isn't as developed, so they don't wall off infection as well. Peritonitis tends to happen earlier and spread faster. So quick surgery is vital. Dehydration and sepsis are also bigger risks for kids.
Okay, prompt action needed in children. What about older adults?
In the elderly, diagnosis can be tricky. Symptoms might be less typical, maybe less intense pain initially. Their abdominal wall can be laxer, so the guarding and rigidity might be less obvious. This often leads to delayed diagnosis, meaning gangrene and perforation are more common. It can sometimes mimic bowel obstruction in this age group.
So higher risk of complications due to delayed diagnosis. And pregnancy. That sounds complex.
It is. Appendicitis happens in about 1 in 2,000 pregnancies, mostly in the first 2 trimesters. As the uterus grows, it pushes the appendix upwards and outwards.
So the pain isn't in the usual spot?
Often not. It's higher up and more to the side. Rebound tenderness and guarding might also be less reliable signs because the abdominal wall is stretched.
Diagnosis must be harder then.
It can be. Plus, white blood cell count is normally higher in pregnancy anyway, but it's the most common non-pregnancy related surgical emergency during pregnancy.
Wow. What are the risks?
There's about a 15% risk of premature labor. And crucially, if the appendix perforates, the risk of fetal loss goes way up. Maternal mortality also increases later in pregnancy. So despite the challenges, surgery is still the standard treatment. Perforation risk is actually highest in the third trimester.
Okay, so always needs serious consideration in pregnancy.
Yeah.
Given all these variations, I bet the list of things that could be causing similar symptoms is huge. The differential diagnosis.
Massive, absolutely.
Yeah.
You have to think about things like a perforated duodenal ulcer that can leak fluid down the right side,
Right.
gallbladder inflammation, cholecystitis, pancreatitis, a kidney stone on the right side, ureteric colic.
All causing right-sided pain.
Exactly.
Okay.
In women, you absolutely have to consider gynecological causes.
Yeah.
A ruptured ovarian cyst, a twisted ovary, pelvic inflammatory disease, PID, and ectopic pregnancy.
Yeah, lots of possibilities in the pelvis.
In kids, maybe Meckel's diverticulitis or intussusception where the bowel telescopes. In older folks, diverticulitis of the colon or even cacal cancer can mimic it.
So how do doctors tell them apart?
It's often subtle clues in the history, the exact nature and timing of the pain, the other symptoms, and the physical exam findings. Sometimes the type of fluid found in the abdomen, if there is any, gives a clue, like bile staining suggests a DU perforation, blood suggests maybe ectopic or a twisted cyst. It's detective work.
Definitely sounds like it. Now, if appendicitis isn't caught early, or if things go wrong, what are the potential bad outcomes, the sequelae?
Well, as we said, mild cases might resolve, but it could come back relapse or recurrent appendicitis. The main worries are the complications, forming that appendicular mass or abscess.
Right.
Perforation is a big one, carries maybe a 20% mortality risk even today if it leads to severe sepsis. Widespread infection peritonitis, septicemia, infection in the blood. A really nasty one is pilophlebitis infection spreading up the portal vein to the liver.
Wow, infection traveling to the liver.
Yeah, very serious. And then bowel obstruction, either from the bowels shutting down temporarily after infection or surgery, no venous, or later on due to adhesions, scar tissue, kinking the intestines.
All things you really want to avoid. So how do doctors confirm the diagnosis? What investigations are used?
Blood tests are usually first. A complete blood count often shows a high white blood cell count, especially neutrophils, signaling infection.
Okay, blood work, then imaging.
Ultrasound is often the next step, especially in younger people or women where you want to rule out ovarian issues. It can show the inflamed appendix, non-compressible, thickened wall over 6 millimeter. Maybe see a phacolith, fluid around it, that target sign sometimes. Figures 24.14a and b show this. It's also good for seeing an abscess or mass.
Ultrasound is useful. What else?
Laparoscopy, putting a camera in, is actually considered one of the best ways, especially if the diagnosis is uncertain, because you can directly see the appendix.
Look inside.
Exactly. There are also scoring systems, like the Alvarado score or modified versions like Column or Rapasa. They combine clinical signs, symptoms, and lab results to estimate the probability.
Like a checklist.
Sort of, yeah. Alvarado uses things like migrating pain, anorexia, nausea, tenderness, rebound, fever, high white count. Helps stratify risk low, medium, high probability.
Okay. What about CT scans?
CT, especially with contrast, is very accurate.
Right.
Often used if the diagnosis isn't clear from ultrasound or in older patients or obese patients where ultrasound is harder. CT can show the dilated appendix, thickened wall, inflammation in the fat around it, dirty fat, fluid, abscess, phacolith, maybe an arrowhead sign pointing to the blocked base. Very sensitive and specific.
CT sounds pretty definitive. MRI, X-ray.
MRI is excellent, especially for pregnant patients because there's no radiation. Plain X-rays are usually not that helpful for diagnosing appendicitis itself, but they might show a phacolith sometimes. Figure 24.13 shows one. Or signs of complications like bowel obstruction or rule out other things like a perforated ulcer if you see free air.
So a whole toolkit of tests depending on the situation. Once the diagnosis is made, treatment is usually surgery, right? And appendectomy. Yeah. What are the ways surgeons can do this?
All right, surgery is the mainstay. There are different approaches. The traditional open surgery uses various incisions. The classic is the gridiron, or McBurney's incision, a small, angled cut in the right lower abdomen.
The one most people picture.
Probably. Rutherford Morrison's is similar but bigger, extends outwards more. Land's incision is more cosmetic, follows a skin crease. For tougher cases or widespread infection, maybe a paramedian or midline incision down the middle.
Okay, different open cuts.
And then there's the laparoscopic approach, keyhole surgery, using small cuts, a camera, and long instruments. That's become really popular, often the standard now. Figure 24.15, shows some of these incisions. Fowler wear is another less common open positioning technique.
Okay, let's stick with the traditional open surgery first. What actually happens during the operation?
Okay, so under general anesthesia, the surgeon makes the incision, carefully goes through the muscle layers, often splitting them rather than cutting, and opens the peritoneum, the abdominal lining.
Enters the abdomen.
Right. They find the cecum, identify the appendix. If the omentum is stuck to it, they gently peel it off. Then they grasp the appendix, find the mesoappendix with its blood vessels.
The important artery.
Exactly. They tie off those vessels with sutures, ligate the mesoappendix. Figure 24.16 shows this. Then, around the base of the appendix, where it joins the cecum, they often place a purse string suture like a drawstring.
Okay.
They crush the appendix base with a clamp, tie it off securely with another suture, transfixion ligature, and then cut the appendix off above that tie.
Appendix out.
Appendix out. Then they clean the stump and tighten that purse string suture to bury the stump into the cecum wall. Though burying the stump isn't always done anymore, it's debated. Figures 24.18 to 24.20 show this process.
Burying the stump. Interesting. What if it's really stuck, like behind the cecum?
If it's difficult, they might do a retrograde appendicectomy, start dissecting from the tip backwards toward the base. If there was pus or it burst, they might leave a drain in.
Okay. And after surgery?
5E fluids, antibiotics usually, pain relief. Once the patient's bowel starts working again, they can start eating and drinking, usually pretty quickly.
Gotcha. Now, even with a common operation like this, things can go wrong.
Yeah.
What are the potential complications after an appendicectomy?
Yeah, no surgery is risk-free. You can get paralytic ileus, where the bowel just stops working for a bit, bleeding either right after surgery or if a ligature slips off the artery.
Yikes.
Residual abscesses, collections of pus, can form elsewhere in the abdomen, like the pelvis or under the diaphragm. That nasty pylophlebitis again, infection of the portal vein.
Right.
Later on, adhesions can form, causing bowel obstruction. Injury to nerves during the incision can rarely lead to a right inguinal hernia. Wound infection is actually fairly common, maybe 10% risk. Figure 24.22 shows one.
10% is quite high.
It is, unfortunately. A fecal fistula, that connection between bowel and skin, is rare but serious. Figure 24.21 shows that too. And general surgical risks like respiratory problems or DVT, blood clots in the legs.
A sobering list. What about problems during the surgery itself? What unexpected things might a surgeon find?
Well, the classic problem is going in and finding a perfectly normal appendix, the lily-white appendix.
What then?
Then you have to look carefully for something else causing the symptoms. Meckel's diverticulum, Crohn's disease, ovarian cyst, tube problems in women, even a tumor somewhere else.
So keep looking.
Absolutely. Or they might find an unexpected tumor of the appendix itself. If it's a small carcinoid at the tip, just removing the appendix might be enough. But if it's bigger, or at the base, or looks like adenocarcinoma, they might need to do a much bigger operation, a right hemicolectomy, removing that whole section of colon.
Depends on the tumor.
Exactly. Very rarely, the appendix might just be missing congenital abscess. Need to be sure you've found the cecum properly. Or they might find a big abscess that needs draining first, or even an unsuspected cancer of the cecum itself, which also needs a hemicolectomy.
What about Crohn's disease?
If they find Crohn's affecting the terminal ileum or cecum, they have to be careful. If the appendix base looks healthy, they might remove it. But if the appendix itself is involved in the Crohn's inflammation, taking it out carries a high risk of fistula formation. So they might leave it and treat with antibiotics and steroids instead.
Tricky decisions. Now, what about taking out a healthy appendix during another surgery, incidental appendicectomy?
Yeah, that's sometimes done. For example, during a hysterectomy or other pelvic surgery in women, especially if they're younger, or in someone with chronic, vague, lower abdominal pain, where appendicitis is maybe on the list but unproven.
Prophylactic removal.
Kind of. Also sometimes done during surgery for intestinal malrotation, LADS procedure, or certain bowel prep procedures. But there are times not to do, definitely not if there's active Crohn's nearby, or after pelvic radiation, or in someone immunosuppressed, or if they have artificial artery grafts nearby.
Okay, specific situations only. Let's pivot to the laparoscopic approach now. You said it's often the gold standard. What are the big advantages?
Laparoscopy has some real plus points. First, you get a great view, so you can confirm the diagnosis and see if the appendix is actually inflamed.
Better diagnosis.
Yes. And you can easily look around at other organs in the abdomen and pelvis, rule out other problems like ovarian cysts or diverticulitis.
See the whole picture.
Right. Because the incisions are tiny, there's generally less pain, less trauma to the muscles, faster recovery, better cosmetic result.
Faster back on your feet.
Usually, yeah. It's particularly good for patients where the diagnosis is unclear, obese patients where open surgery is harder, women of childbearing age, suspected pelvic or subhepatic appendix, or for that interval appendicectomy after a mass is settled. Figures 24.29 to 24.31 show the setup.
Sounds great. Any downsides? When might it not be the best option?
Well, it can be technically trickier, especially if the appendix has ruptured badly and there's pus everywhere, severe peritonitis. It requires specialized equipment and training, so it might be more expensive and not available everywhere.
Cost and availability.
Yeah. And surgeons always need consent to convert to an open operation if they run into trouble laparoscopically.
Makes sense. Can you walk us through the laparoscopic procedure briefly?
Sure. General anesthesia again. Patient positioned often head down, tilted right. Small cut near the belly button for the camera port. One or two other small cuts in the lower abdomen for instruments.
Ports for camera and tools.
Right. Inflate the abdomen with CO2 gas pneumoperitoneum to create working space. Find the appendix, grasp it. Identify the mesoappendix, seal and divide the blood vessels using energy devices or clips. Dissect the appendix free up to its base.
Okay. How do they deal with the base?
Usually ligate it, tie it off. Can use pre-tied loops pushed down through the ports or tie knots inside the abdomen,
Right.
supracorporeal suturing, or use special stapling devices.
Secure the stump.
Exactly. Then the appendix is put into a small retrieval bag and removed through one of the ports to avoid contaminating the wound. Close the small port sites, maybe leave a drain if it was gangrenous or perforated.
And recover.
Often pretty quick. Fluids soon after, maybe food within 12 hours or so. There's also a laparoscopic assisted technique sometimes.
Assisted.
Yeah, if the cecum's mobile, they might free up the appendix laparoscopically, then pull it out through the umbilical port incision, ligate the vessels and base outside the body, then put the stump back in. Can be faster sometimes.
Interesting variation. Are there complications specific to laparoscopy?
Yes, some risks are more related to the technique. Injury to bowel or blood vessels when inserting the sharp ports. Problems from the CO2 gas, like it getting under the skin, or very rarely into a blood vessel. Accidental burns from the energy devices, bleeding that's hard to control laparoscopically, maybe perforating the appendix while handling it, ligature slipping off the stump later, causing a leak or fistula.
So different risks to weigh up. Okay, let's quickly cover some related conditions. The appendicular mass or phlegmon.
Right. That's when the body successfully walls off the inflamed appendix. Usually takes 3 to 5 days to form. It's a lump made of appendix, omentum, bowel loops, all stuck together.
And the treatment isn't always immediate surgery.
Correct. Often, the initial treatment is conservative, the Ochsner-Sharon regimen. Hospital observation, IV antibiotics, fluids, pain relief, maybe NGT suction. About 90% resolved this way.
Then surgery later.
Yeah, usually an interval appendicectomy about 6 weeks later once everything's calmed down.
Yeah.
But you do operate immediately if the diagnosis is uncertain, if it's a child or elderly person with acute symptoms, if it looks like it's burst or gangrenous already, or if they develop diffuse peritonitis.
Okay. And the appendicular abscess, different from a mass.
An abscess is a collection of liquid pus, whereas the mass is more solid inflammation initially. Abscess can form within a mass or just directly from perforation, often retrocecal. Patient is usually sicker, high fever, toxic.
How's that treated?
Ultrasound or CT confirms it. Treatment is usually antibiotics plus drainage. Often, drainage can be done percutaneously, sticking a needle or drain in under CT or ultrasound guidance. Sometimes open surgical drainage is needed.
Drain the pus first.
Right. Then, again, interval appendicectomy. But usually later, maybe 3 months after the abscess is resolved. Pelvic abscesses can sometimes be drained via the rectum or vagina.
We also touched on fecal fistula after surgery. What causes that?
Usually happens if the appendix was really bad, gangrenous, perforated, friable base that didn't hold sutures well, or after draining an abscess or operating on a mass too early. Underlying conditions like Crohn's or TB can also predispose to it.
And the sign is?
Fecal discharge from the wound or drain site. Nasty. Treatment is often conservative. First manage infection, fluids, protect the skin, wait and see. Most heal on their own if there's no downstream blockage or specific disease. If it persists after, say, 6 weeks, might need surgery to resect that bit of bowel.
Okay. Lastly, mucocell and pseudomyxoma peritoneae. Sounded quite different.
They are. Mucocell is that mucus-filled appendix due to blockage at the opening, usually benign, caused by a simple stricture. Appendix just gets bigger and bigger with mucus. Might cause mild pain, can get infected, empyema.
And pseudomyxoma.
That's the serious complication. Usually, if a mucocele caused by a low-grade appendiceal cancer, or sometimes an ovarian cancer, ruptures, the abdomen fills with this thick, jelly-like mucus.
Jelly belly.
Kinda, yeah. Progressive abdominal swelling, often painless initially. Treatment is tough. Big surgery to remove as much jelly and involved organs, appendix, ovaries, omentum as possible, maybe chemo. Prognosis often poor. Simple mucocilias are just treated by appendicectomy.
Wow, quite a spectrum from simple inflammation to that. Okay, bringing this deep dive towards a close, what are the big takeaways about the appendix?
Well, we've seen its anatomy isn't always simple. Location varies, size varies. We've unpacked how appendicitis happens, that progression from inflammation to obstruction, gangrene, perforation.
Yeah.
We've looked at how it's diagnosed, the clinical signs, the scores, the vital role of imaging like ultrasound and CT, and how treatment has evolved, especially with laparoscopy becoming so central.
It really strikes me that this organ, often called vestigial or useless, causes such a common and potentially serious problem. There's a whole medical history wrapped up in understanding and treating it.
Absolutely. And it makes you think, doesn't it? All that lymphatic tissue, the abdominal tonsil thing.
Mm-hmm.
Could it actually have a more important immune function than we generally appreciate?
A hidden role?
Maybe. What else might future research uncover about its job? And how will surgery continue to evolve? It seems simple, but there's still a lot we're learning. Definitely something to keep an eye on.